class, welcome to our sixth module where you're going to be learning about adolescence. In this module, you'll be learning about the physical, cognitive, and psychosocial changes that are happening during adolescence. You'll learn about growth, puberty, sleep, nutrition, and pregnancy during this period of time. You'll also be learning about cognitive development, where you'll explore concepts like formal operational thought, adolescent egocentrism, and education. And then you'll be learning about psychosocial development, where you'll learn about the search for identity and the different types of identity outcomes. You'll also learn about self-concept and parent and peer relationships. I've divided this module into 3 separate videos. So your first video will be on physical development. And then the second video will be on cognitive development. And then finally, the third video will be on psychosocial development. So let's get started. As you learn about physical development in adolescence, you'll first learn about the overall physical growth that's experienced during this time. You'll also then be learning about the changes that happen during puberty, and you'll learn about the changes in brain maturation. You'll learn about the changes in sleep, and you'll also learn about something called gender intensification. You'll learn about nutritional concerns as well and eating disorders, since we know that this is a time when individuals are particularly vulnerable to disorders like anorexia and bulimia and binge eating disorder. And then you'll also be learning about the prevalence, the risk factors, and the consequences of adolescent pregnancy. Puberty is a time of rapid growth and sexual maturation, and it denotes 2 types of physical changes that mark the transition from childhood to young adulthood. The first are the bodily changes, and this includes increases in height and weight, as well as changes in the body's fat and muscle content. The second concern is sexual maturation, and this includes changes in reproductive organs and the appearance of secondary sex characteristics like facial and body hair and the growth of breasts. For physical growth, the elementary school years, they represent the calm before the adolescent storm. In an average year, a typical 6 to 10-year-old gains about 5 to 7 pounds and grows 2 to 3 inches. In contrast, though, during the peak of adolescent growth, a girl may gain as much as 14 pounds in a year and a boy as much as 16 pounds. Puberty usually starts somewhere between 8 to 14 years of age, and of course it varies from child to child. Girls typically start their growth spurt at about age 11, and they reach their peak rate of growth at about 12 years of age and achieve a mature height or stature at about 15. Boys, on the other hand, they start a growth spurt at about age 13, and they hit a peak growth at about 14 and then reach their mature height by about 17. So there's a 2-year difference in a growth spurt. And this, of course, as many of you might remember from when you were in school, this can lead to some awkward social interactions between 11 and 12-year-old boys and girls, because girls are often much taller and they look much more mature than boys. During this time, we see what's called distal proximal development, where growth proceeds from the extremities towards the torso. So body parts also don't mature at the same rate. Instead, the head, the hands, and the feet, they usually begin to grow first, and then this is followed by growth in the arms and the legs. And then the trunk and the shoulders are the last to grow. And these differing growth rates can cause, as some of you might recall or might notice, they can cause growth rates that the growth rates can cause an adolescent's body to look out of proportion. So, teens that have a head and hands that might be too big for the rest of their body. But then these imbalances don't last for long as the later developing parts catch up. Not only do adolescents become taller and heavier, they also become mature sexually, and sexual maturation includes a change in what are called primary sexual characteristics. And this involves organs that are directly involved in reproduction. These include the ovaries, the uterus, the vagina in girls, and the scrotum, the testes, and the penis in boys. This is an image from your textbook that's of the male reproductive system. And as individuals go through puberty, we see the development of the reproductive system that's allowing then for males to reproduce. You're not going to be asked to label or identify any parts of the reproductive system, but I think it's helpful for you to have some perspective on what's happening during this period of time. And I'd encourage you to make sure that you take a look in your textbook at the development that's taking place in both males and females. You'll see here the female reproductive system. I think it's really interesting to note that all women are born with all of the eggs that they're ever going to have. That's pretty amazing, I think, to think that when you were developing in your mother's womb, that you were actually developing the eggs that you were going to have that potentially would then be combined with sperm to then lead to the development of another human being. It's pretty amazing. This also is interesting too because we know how important it is then to have good health and to take care of our health throughout our lifespan, especially early in life and as we think about like our teens and our 20s and 30s, to keep up with our health and to make sure that we're not exposed to lots of toxins in the environment or anything that might have a negative effect on our eggs. Sexual maturation also includes changes in secondary sex characteristics, and these are physical signs of maturity that aren't directly linked to the reproductive organs. This can include the growth of breasts and the widening of the pelvis in girls, and the appearance of facial hair and the broadening of shoulders in boys, and the appearance of body hair and changes in voice and skin in both boys and girls. A key factor that's involved in the physical changes that happen during puberty is the pituitary gland. It releases a growth hormone that signals other glands to secrete hormones. And during the early elementary school years, the pituitary gland signals the adrenal glands to release what are called androgens. And then this initiates biochemical changes that produce body hair. And then a few years later, the girl's pituitary gland signals the ovaries to release estrogen. And then this causes the breast to enlarge and female genitals to mature and fat to accumulate. In boys, the pituitary gland, it signals the testes to release the hormone testosterone, which causes the male genitals to mature and muscle mass to increase. So those are the biological underpinnings of puberty. But what about the environment? So the timing in part of puberty is regulated by genetics, but genetic influences are very much influenced by our environment, in particular by an adolescent's nutrition and their health. So puberty actually occurs earlier in adolescents who are well nourished and who are healthy than in adolescents who aren't. So for example, a girl's first period occurs earlier in parts of the world where nutrition and healthcare are adequate, like in many places, like in Europe and in North America. I think it's also interesting to note too that the social environment influences the onset of puberty. So for young girls who are experiencing chronic stress or who are depressed, their first period tends to start at a younger age. And so, the research actually suggests that for girls who have mothers who use harsh punishment and have used harsh punishment when they were preschoolers and young children, that those girls actually have their first period at a younger age than those girls whose mothers did not do that. And then, so overall, when girls are experiencing socio-emotional stress, where where if their family life is harsh and they lack warm, supportive parents, the hormones that are elicited by this stress may potentially be activating the hormones that trigger a girl's first period. Race and ethnicity also are related to the age of puberty. So the onset of puberty tends to begin later for Caucasian girls than it does for Mexican American and African American girls, for example. And puberty typically starts later for Asian American girls than it does for many other ethnicities. Also, although puberty begins around on average, and I gave you a range, an age range earlier, but on average, at age 11 for a girl and 13 for a boy, for many children, puberty begins months or even years before or after these norms, and maturing early can particularly affect girls. Girls who mature very early, this seems to have a negative effect on self-confidence, and these young girls are also more likely to be depressed, and they're more likely to have behavior issues, and they're more likely to smoke and drink. Early maturation can sometimes lead girls into relationships with older boys, and often, these girls are not prepared to cope with the demands of these relationships. And then, of course, this in turn can result in some very life-changing effects on these young girls who may be pressured into sex and then may become mothers while they're still teenagers. I think it's very important to note, though, that when early maturing girls have warm, supportive parents, they're less likely to suffer the harmful consequences of early maturation. Now, this is in contrast to what boys experience. So, maturing early for boys, this may not have as negative effect on a boy's self-esteem. However, young boys are still at a risk when they experience early maturity to, they're likely to spend more time with older boys, and then this may expose them to risky behaviors. Early maturing boys tend to be viewed more favorably than early maturing girls. But at the same rate, though, early maturing boys may then be hanging out with guys that are more mature and whose brains are more developed than theirs are. And so then they may not be prepared to make the choices that their older, more matured or their older counterparts are. And I mean, when I say older, more matured, I mean older, more matured in terms of brain development. And that can have a significant effect on boys. During adolescence, the brain becomes more interconnected and specialized, and the corpus callosum thickens. If you'll remember, the corpus callosum is the band of nerve fibers that allows for communication to take place between the right and left hemisphere. Also, you see that during adolescence, the connections are strengthened between the hippocampus and the frontal lobes. So at the beginning of adolescence, the brain, it is nearly full size, but here what you're seeing is that it's really being fine-tuned. And so what we're seeing more specifically related to the brain in regards to very, very specific changes are related to myelination. And this is the acquisition of fatty insulation that makes neurons transmit information faster. And it also, what we see here too, is synaptic pruning, which is that weeding out of unnecessary connections between neurons. So these changes mean that different regions in the adolescent brain, they are well connected and information is rapidly conveyed between them. And this allows adolescents to process information more efficiently than children. We also see a decrease in plasticity at this stage as well. During puberty too, the increases in estrogen and testosterone, that results in binding the receptors in the limbic system. And this not only stimulates sex drive, but it also increases adolescent emotional volatility and impulsivity. Also, I think it's important to note too that what we see is an increase in novelty seeking. And so this means that there's going to be more risk taking. At the same rate, though, while the prefrontal cortex is continuing to develop, it's still not fully developed. And so here we're coupling then novelty seeking, risk taking with a brain that's not fully developed. And so the consequences are still not really going to be as very well thought out in comparison to that of a fully developed adult brain. So teens are weighing the risks and rewards differently than adults. And increased dopamine during this time is associated with more attention being paid to rewards and less to the risks. So overall, the brain systems that are sensitive to reward, especially to rewards from peers, for example, they reach maturity in adolescence, but the systems that are responsible for self-control, they're not fully specialized until adulthood. And so you have this combination here taking place with, where you have an increase in risk taking and a sensitivity to rewards, and yet a brain that is not fully developed, especially in the areas related to self-control. So this can result in some poor decision making. In figure 6.6 here, we have an image where you have the limbic system identified. And the limbic system, as we have talked about in earlier chapters, it is responsible for such important functions as emotion and motivation. And during adolescence, a part of the limbic system that's called the amygdala, it's thought to connect sensory information to emotional responses. And it's important in particular for the fear response, but also for additional emotional responses. And so its development along with hormonal changes, this can give rise to some of the newly intense experiences that happen in adolescence of rage and fear and aggression, or excitement and sexual attraction. Now, over the course of adolescence, the limbic system comes under greater control of the prefrontal cortex. And that's, again, because the prefrontal cortex is continuing to develop. It's as the brain is developing and the adolescent moves into early adulthood. In figure 6.6 here, we have an image where you have the limbic system identified. And the limbic system, as we have talked about in earlier chapters, it is responsible for such important functions as emotion and motivation. And during adolescence, a part of the limbic system that's called the amygdala, it's thought to connect sensory information to emotional responses. And it's important in particular for the fear response, but also for additional emotional responses. And so its development along with hormonal changes, this can give rise to some of the newly intense experiences that happen in adolescence of rage and fear and aggression, or excitement and sexual attraction. Now, over the course of adolescence, the limbic system comes under greater control of the prefrontal cortex. And that's, again, because the prefrontal cortex is continuing to develop. It's as the brain is developing and the adolescent moves into early adulthood. An important issue during adolescence is pregnancy and sexual activity. So the percentages of unmarried teenagers who engage in sexual intercourse is actually on the decline, and it dropped to about 50% when we went to the year 2000, and then today it's at about 42%. So teenage birth rates have also been declining steadily, and they now stand at their lowest in more than 70 years. So that said, though, the birth rate among US teens still exceeds that of many developed countries. Now, while some teen mothers become pregnant to perhaps, to fulfill an emotional void or to rebel against their families, most teenage pregnancies result from failure to use contraceptives reliably. So many sexually active teenagers, they get caught up in their own personal fables, and we'll be looking at the concept of personal fables. And this then leads them to believe that pregnancy is something that could not happen to them. I think it's important to note that unwed teenage mothers face very serious obstacles to their educational and their social development, and they're more likely than other girls to live below the poverty line, to quit school, and then to depend on public assistance. And although the father, who's usually a teenager himself, is equally responsible for the pregnancy, according to research, he's usually absent and not very capable of contributing to the child's support. So why do some teens become sexually active, whereas others abstain? Well, for one thing, peer pressure, whether it's real or it's imagined, this can promote or restrain sexual activity. Moral reasons, on the other hand, are often a basis for restraint. Teens who abstain may also be concerned about getting caught, becoming pregnant, or contracting a sexually transmitted disease. And then other factors linked to sexual restraint among teens include living in an intact family, having a family with low levels of conflict, having at least one parent who graduated from college, placing an importance on religion and attending religious services frequently, and then having less exposure to sexual content in the media. Figure 6.8 in your textbook shows the significant decline that has happened between 1991 and 2013 for live birth rates for young girls and women ages 15 to 19. And this is true for all races and ethnicities. And if we look at even more recent data, the teen birth rate in the US is actually at a record low, and it has dropped below 18 births per 1,000 girls and women between ages 15 to 19. And this is the first time that it has been this low since the government began regularly collecting data on this group. So what are some of the reasons that we're seeing a significant decline? There are many potential reasons, but researchers suggest that some significant reasons could be tied to less sexual activity, the use of more effective contraception, and more information about pregnancy prevention. So more specifically related to these reasons, let's take a look at the percentage of young girls who are reporting engaging in sexual activity. If we look at women and young girls ages 15 to 19 and the frequency by which they report, or the percentage of young girls and women who are reporting having engaged in sex, if we look at 1988, it's actually at 51%, and between 2011 and 15, the rate was at 42%. And the majority of teens who are having sex report using contraception. And also, I want to point out too that in terms of the use of more highly effective contraceptive methods, it turns out that there's been an increase in the percentage of young girls who are using implants and IUDs, which is thought to be it's a longer acting, of course, reversible contraceptive and perhaps more effective than other means of contraception. And then three, I should say, pregnancy prevention programs and messages that are directed toward teens may have actually played a role as well. And researchers have found that reality TV shows that follow the struggles of teen mothers, like MTV programs 16 and Pregnant and Teen Mom, that they may have contributed to up to a third of the decline in teen births in right before 2010. Now, of course, we're talking about percentages today in 2020, but still, when researchers were looking at that time period when shows like that were very popular, and they still are popular, that was contributing to a significant reduction in teen births potentially. Now, some of you may think that, okay, so perhaps we're seeing a decline in live births, but does this mean that we're seeing an increase in abortion rates? And actually, the abortion rate among 15 to 19-year-old girls and women has also been declining, and it's declined significantly. If we look at the research, actually shows that 44 per 1,000 in 1988, and then it declined to 10.6 per 1,000 in 2013. So this is a significant decline. So it's not just that we're seeing a reduction in live births because young girls and women are terminating pregnancies. They may actually be, like I said, engaging in sex less often. So we're seeing young girls who are not being sexually active. They're using more effective means of contraception. And then also perhaps we're seeing the influence of programs like MTV 16 and Pregnant, and perhaps other messages being directed at young teens about the actual struggles that teen mothers experience when they're pregnant. So let's take a moment to reflect. Obesity prevalence among 12 to 19-year-olds in the US is at 20.6%. That's a really high number. 1 in 5 people, 12 to 19, are obese. Now, if you look at the map on the left, you'll see a map of obesity rates in the US among adults. Now, why do I have a map of adult obesity? Well, it's because obese children often remain obese in adulthood, and the risk of obese adolescents becoming obese adults is even greater than it is among young children. So also, when we think about the origins of obesity, it often begins in childhood and adolescence. So if we can identify the factors that are contributing to childhood and adolescent obesity, perhaps we can reduce adult obesity, which we know can have some very significant health consequences. So what is obesity? Well, obesity typically we think of as being associated with BMI or body mass index. And you can easily go online. You can do an internet search for BMI, which takes into account a person's height and their weight. And then when you are above a certain number, 30, then that indicates that a person is falling within that range of obesity. Now, with adolescents and kids, they also look at percentile. Where does this person fall in comparison to other kids that are their age and are their height? So that's also taken into consideration. So what do you think is contributing to the increasing rise in obesity? You'll see here 3 times the number of children and adolescents suffer from obesity now compared to 1 generation ago. Ask your parents or people who are from the previous generation. Ask them, what was life like? What were they eating? Did they spend much time watching television? Maybe they did. Maybe they didn't. Were they spending more time outdoors than kids today? I know for myself, when I look outside, I see very few kids playing in my neighborhood compared to when I was a kid. But that's anecdotal. That doesn't mean that that's what's going on. If we really want to understand what is causing obesity, we have to look at what the research has to say. So in order for us to look at what is contributing to the increase in obesity, we have to fully look at what causes obesity. And many of us know these things, right? We probably know that genes are linked to obesity. So for example, a person who has a family member, especially a parent, if you have an obese parent, this can significantly rise or increase a child's risk for becoming obese. Now, I want to point out that obesity is due to a combination of factors. So it's not just a gene or series of genes. There can be lifestyle factors and socioeconomic factors that may cause certain genes to be expressed. So it's not as though environment and our biology are operating separately. These things are interacting with one another, and researchers still are not fully aware of what is happening with this interaction. There's still a lot to be understood. So metabolism is another factor. We know that each person's body uses energy differently. You've all had a friend who seems to be able to eat whatever they want and not gain weight, and then maybe you have another friend who they just eat a small amount and they gain weight. So we know metabolism and hormones can have an effect on obesity. Obesity is also linked to socioeconomic factors. So there's a strong tie between economic status and obesity. Obesity is more common among people who have lower incomes, and in some places, people may have limited access to affordable, healthy foods, or they may not have a safe place to exercise. And this tends to be more likely to happen in poorer neighborhoods. And of course, then another factor linked to obesity is lifestyle choices. So overeating and an inactive lifestyle both contribute to obesity. A diet full of sugary, high fat, and refined foods, of course, can lead to weight gain. And as you know, so too can a lack of regular exercise. And then additional lifestyle factors like watching a lot of TV or sitting at a computer for long periods of time. So as we think about obesity and lifestyle factors, we might ask ourselves about, why is it that people are eating unhealthy foods? What is the reason? Well, of course, we know unhealthy foods may be sometimes, for some people, taste better, but oftentimes people may feel that unhealthy foods are a more affordable option. So researchers at Harvard actually wanted to study what the cost differences were between healthy and unhealthy diets. And so what they did is they conducted some research to kind of figure out the cost difference between a diet that was full of fruits and vegetables, fish and nuts, versus an unhealthy diet. Those foods that are rich in, that are very processed, and they are, like meats and refined grains. And what they found is that on average, a day's worth of the most healthy diet pattern costs about $1.50 more per day than the least healthy ones. Now, this may not sound like a lot of money, and this is per person, $1.50 per day, but it actually can be quite a bit of money for many people, especially if we're talking about families. So for a single person, this is about $550 per year. And while this, may seem manageable for many people per year, when we're talking about a family of 4, of 5, of 6, when you're talking about bigger families, this can be very expensive. So why do you think that unhealthy foods cost less? What is the reason? Well, the researchers suggest that unhealthy diets may cost less because food policies focus on the production of inexpensive, high-volume commodities like our corn, for example, corn products. Our government subsidizes, in other words, they pay in excess to farmers for corn products. They pay, they subsidize for soybeans and wheat. And while some of these foods, and I think there are 9 different foods, and some of them as a whole, like individually, may not seem like they're that unhealthy, they actually are very frequently used in processed foods. And so if the government is subsidizing these things, and the government's also helped to develop food policies that make these products less expensive as well, food policies that are related to things like transportation and processing and manufacturing, then it makes these foods less expensive. And so the foods that are healthier aren't the ones that are getting subsidies, and they're not being targeted for policies that benefit them. And so this then means that our food that is healthy is going to cost quite a bit more overall, especially for families. And so then families end up suffering the consequences because you're faced with making a short-term versus long-term choice. And you might not even have the choice. You may, think about it. You might not have the choice. You have X amount of dollars to spend on groceries, and healthy foods just exceed that budget that you have. But even if you do have close to that amount, you may make the decision not to because in the short term, it seems less expensive, but in the long term, we know that obesity is very, very expensive because of the health consequences associated with it. Of course, there are additional effects or causes of obesity, including things like for adolescents, endocrine disorders and diseases, and different medicines. But what has changed in recent years? Why is there this tripling of the number of kids who suffer from obesity when compared to a generation ago? Is it less time spent outdoors engaging in physical activity? Is it less time spent in physical education classes? Is it less, or is it eating more unhealthy foods? Are parents more stressed and feeling like they have less time to prepare healthy meals and perhaps relying more on processed foods? Well, let's just look at a couple of things. So when we think about physical activity, if we go and we look at the amount of time that children and adolescents spend engaging in physical activity, only about 21.6% of kids and adolescents ages 6 to 19 meet the recommended 60 or more minutes of moderate to vigorous activity at least 5 times per week. That means almost 80% don't. What about physical education? Ask your parents how much time they spent in physical education when they were kids. Compare that to your experience. Now, there may not be much difference between you and your parents, but overall, we know across the US that many schools have decreased the amount of time that kids spend in physical education. This not only has some immediate effects, it also can have long-term effects about how kids view physical activity. Why are they spending less time, do you think? What's the reason? Well, actually, physical education classes are pretty inexpensive, so it's not the cost. Well, if we think about it, what are they focusing on? What are they pressured to do? Well, they're pressured for their students to do very well on standardized testing. So more time is going to be then focused on standardized testing versus on physical activity. But what do we know about physical activity? We know it's not only good for our body, but it also promotes self-esteem and can even sharpen concentration and boost academic performance. So, yes, we have seen an increase in obesity. There are many different potential factors contributing to it. What can we do as a society to address this very serious issue? That's something for each of us to think about. Eating disorders are another important issue faced by adolescents. I do want to point out, though, that eating disorders can begin as early childhood, and they can start as late as very late adulthood, but they do often begin in the teen years. Eating disorders are very serious, potentially life-threatening conditions that can affect a person's emotional and physical health. They affect both males and females, and they are common across all cultural groups, with anorexia nervosa being more common in non-Hispanic Caucasian people. There are a multitude of factors that can contribute to the development of eating disorders, and it seems as though it involves an interaction of biological, environmental, and psychological factors. The Diagnostic and Statistical Manual is a handbook that's used by healthcare professionals in the United States and much of the world as an authoritative guide for the diagnosis of mental disorders. The DSM stands for Diagnostic and Statistical Manual, and 5 means 5th edition. And the DSM contains descriptions and symptoms and other criteria for diagnosing mental disorders. And it also provides a common language for clinicians to communicate about their patients and to establish consistent and reliable diagnoses that can be used in the research of mental disorders. It also provides a common language for researchers to study the criteria for potential future revisions and to aid in the development of medications and other interventions. So the DSM manual is in its 5th edition, and the DSM has been periodically revised ever since it was published back when it was first published back in 1952. And so it's the new manual, the most recent edition, has it reflects the most recent up-to-date research on disorders, and some disorders that were not included before in the 4th edition. There was a specific edition called the 4th edition TR, and currently in the 5th edition there are disorders that were not included. There are also disorders that now have a different name, and so each edition of the DSM manual is a reflection of the updates in research and knowledge within the field. So the 5th edition provides diagnostic criteria for disorders that are officially recognized by the American Psychiatric Association, and 3 of them that are relevant to this chapter are listed here. And those are anorexia nervosa, bulimia nervosa, and binge eating disorder. And you see some of the symptoms. These are not all of the ones that are listed in the DSM-5 manual. And if you're interested in knowing more about the very specific criteria that need to be met for there to be a diagnosis, I would encourage you to do a Google search for DSM-5 and whatever disorder you're interested in learning more about. Also, you can go to the Northeast State Library, and they do have one in the reference section for students to look at. You can also, of course, find, if you're interested in purchasing this, you can also find them available for purchase online, and because it's been out for quite some time, the 5th edition you would probably be easily able to find used versions. So the DSM-5 manual provides the symptoms for, let's start first with anorexia nervosa. And so these are just some of the symptoms. So anorexia nervosa is characterized by a restriction of energy intake that leads to a significantly low body weight. Also an intense fear of gaining weight and a disturbance in one's self-evaluation regarding weight. Now, sometimes what you'll find also is when individuals are anorexic, that they will maintain excessive, rigid exercise programs despite weather, fatigue, or illness, or energy that they might already have, or injury, and also that There may be a preoccupation with weight and food and calories and fat grams and dieting, and the person may make frequent comments about feeling fat. The person may dress in layers to hide their weight loss or to stay warm. Okay, so let's take a look at bulimia. So bulimia the symptoms of bulimia include recurrent episodes of binge eating, recurrent inappropriate compensatory behaviors to prevent weight gain, including purging, laxative, fasting, or excessive exercise. Another one could be abuse of diuretics, and also self-evaluation is unduly affected by body weight and shape. Some of the additional things that you might see with this disorder might include a person hiding calluses on the back of their hands and knuckles from self-induced vomiting. Sometimes you will see dental problems like enamel erosion, cavities, discoloration of teeth from vomiting or tooth sensitivity. You might also see some evidence of purging behaviors like frequent trips to the bathroom after meals, some signs or smells of vomiting, presence of wrappers or packages of laxatives or diuretics. And with binge eating disorder, the symptoms include recurrent episodes of binge eating, marked distress regarding binge eating, and the binge eating is not associated with the recurrent use of inappropriate compensatory behavior. So if someone is trying to get rid of the weight through purging, whether it be through vomiting, laxative fasting, or excessive exercise, then that would not qualify as binge eating disorder. Some additional things that you might see include like secret recurring episodes of binge eating. So not only just recurrent episodes, but sometimes people will eat in secret, or they might eat in a discrete period of time, an amount of food that's much larger than most individuals would eat under similar circumstances. The person may feel a lack of control over their ability to stop eating. They may feel feelings of disgust, depression, or guilt after overeating, or feelings of low self-esteem. They may steal or hoard food in strange places. They may create lifestyle schedules or rituals that make time for binge sessions. And there might be evidence of binge eating, like the disappearance of large amounts of food in a short time period, or a lot of empty wrappers and containers that might indicate the consumption of large amounts of food. Overall, the chance of recovery, which we'll be talking about treatment in a moment, it increases the earlier an eating disorder is detected. So it's important to be aware of some of the warning signs of an eating disorder. What I shared with you just now, though, in addition, those that were in addition to what are listed on the slide, they are not intended as a checklist. So not everyone who has an eating disorder is going to have all of the warning signs and symptoms at one time. And it's important to keep in mind that warning signs vary across eating disorders, and they don't always fit into neat categories. So really what I'm providing for you is intended as an overall general overview of the types of behaviors that may indicate a problem. There are specific short-term and long-term health consequences of each of these disorders. And for example, for anorexia, an individual is at a significantly increased risk for osteoporosis, heart failure, and issues with fertility and death. For bulimia, digestive problems, tooth decay, and heart trouble, electrolyte imbalances. And then for binge eating, high blood pressure and cholesterol and diabetes. And these are just a few. Now, I want to point out that overall, there are some very important symptoms of overall eating disorders, and of course, some are more specific to specific eating disorders. So overall, specific systems of our body can be affected when we have an eating disorder. So let's take a look first at the cardiovascular system. So when a person's consuming many fewer calories than they need, this means that the body's going to be breaking down its own tissue to use it for fuel. And so muscles are some of the first organs that are broken down, and the most important muscle in the body is the heart. So pulse and blood pressure begin to drop as the heart has less fuel to pump blood and fewer cells to pump it with. The risk of heart failure it rises as the heart rate and blood pressure levels sink lower and lower. Also, purging by vomiting or laxative, it depletes your body of important chemicals, as I mentioned a moment ago, called electrolytes. And so the electrolyte potassium plays an important role in helping the heart beat and muscles contract, but it's often depleted by purging. Other electrolytes like sodium and chloride, they can become imbalanced by purging or drinking excessive amounts of water. Electrolyte imbalances overall, they can lead to irregular heartbeats and possible heart failure and death. And then also a reduced resting metabolic rate can be the result of a body's attempts to conserve energy. So we see here some significant potential effects on the cardiovascular system. In terms of gastrointestinal health, here we have, let's think about what we're talking about here is the overall digestive system. So slow digestion can happen. And so food restriction and or purging by vomiting, it interferes with normal stomach emptying and the digestion of nutrients. And then this, as you can imagine, can lead to stomach pain and bloating, can lead to nausea and vomiting, also can affect blood sugar levels and lead to blood sugar fluctuations. Also, blocked intestines from solid masses of undigested food. Another issue with the gastrointestinal system potentially is are bacterial infections, and then feeling full after only eating small amounts of food. Also associated with eating disorders that's related to the gastrointestinal system is constipation. And this can have several causes. So if someone's not consuming enough nutrition, this means then that there's not enough in the intestines for the body to try and eliminate. And then long-term inadequate nutrition, it can weaken the muscles of the intestines and then can leave them without the strength to propel digested food out of the body. And then when we're thinking about bulimia, when someone is abusing laxatives, this can damage nerve endings and it can leave the body dependent on them to have a bowel movement. Also, in terms of binge eating, which binge eating on its own or binge eating coupled with purging can lead to, it can increase the risk of stomach rupture, which can create a life-threatening emergency. When we think about bulimia and vomiting, which I also want to point out here that sometimes individuals with anorexia will vomit. They may use purging as a way to get rid of any food that they consume. And so you might see a person who has anorexia and that becomes like a feature of their anorexia, but it's not the dominant feature. And so they're still diagnosed as being anorexic. So someone who's vomiting, this of course can wear down the esophagus and it can cause it to rupture. And this is a life-threatening emergency as well. And then when someone makes themselves throw up over a long period of time, their salivary glands that are under the jaw and in front of the ears, they can become swollen. And this can also happen when a person stops vomiting. So so even when they're no longer doing that, their salivary glands are affected. And then both also the malnutrition and the purging can cause something called pancreatitis, and this is an inflammation of the pancreas. And some of the symptoms of that can include pain and nausea and vomiting. Now, for people who are bulimic and who are potentially abusing laxatives and who have become dependent on them, and then with that dependency, they may experience a bowel obstruction. And this can, this bowel obstruction really is a blockage that prevents food and water from passing through the intestines. Also, there are neurological symptoms potentially of eating disorders. So keep in mind, the brain only weighs about 3 pounds, but it consumes about 1/5 of the body's calories. So anytime a person is dieting, fasting, or especially if they're starving themselves, or if they're eating erratically, this means then that the brain isn't getting the energy that it needs. And this then can lead to obsessing about food and difficulties in concentrating as your brain is trying to signal to you that it needs this in order to function. Also, when people are very hungry, when you haven't been eating enough, or if you're very full, perhaps you've overeaten and binge eating disorder, this then can make it difficult to fall asleep or stay asleep, and so it can contribute to insomnia. Also, when we think about the brain earlier in the semester, we talked about neurons being insulated by the myelin sheath, and the myelin sheath has an important role in speeding up the neural impulse and insulating the neuron. And so when someone is not getting enough fat, this can then damage the protective layer, which can cause then some physical symptoms in the body like numbness and tingling in the hands and feet and other extremities. It's also important to note, if you'll remember from earlier readings, that your neurons use electrolytes to send electrical and chemical signals. So we're talking about potassium, sodium, chloride, and calcium. And so severe dehydration and electrolyte imbalances, this can lead to seizures and muscle cramps. Also neurological too, with in terms of the effects of eating disorders, if the brain and the blood vessels can't push enough blood to the brain, it can cause an individual to faint or to feel dizzy. And then also, if someone has binge eating disorder and they have gained a lot of weight, this can increase the risk of sleep apnea. And many of you may be familiar with sleep apnea, where a person regularly stops breathing while asleep. And this, of course, is dangerous because when someone's regularly not breathing throughout the night, when they stop breathing, this can lead to increases in blood pressure throughout the night that are ultimately hidden, because it may not show up during the day when they go to the doctor and their blood pressure looks somewhat normal. When they are sleeping, they have this increase in blood pressure, which then can increase the risk of stroke. There are also hormone effects or endocrine effects from eating disorders. These can include an effect on sex hormones like estrogen and testosterone, and then also thyroid hormones. So when we think about sex hormones, lowered sex hormones, this can cause menstruation to fail to begin, or it can make it irregular or stop completely. And this is something that can happen, especially with what is seen with anorexia. Also, lowered sex hormones can also lead to increase in bone loss, and this then can increase the risk of broken bones and fractures. Also, over time, binge eating can possibly increase a person's chance of becoming insulin resistant. And so insulin is a hormone that many of you are familiar with that lets the body get energy from carbohydrates. And so if they're becoming resistant to this, this then can lead to what many of you are familiar with type 2 diabetes. Also, in terms of eating disorders, when someone isn't getting enough of the energy that they need, the core body temperature will drop and a person can experience hypothermia. And then I also want to mention too that when someone is starving themselves, so in the case of anorexia, this can actually increase one's cholesterol levels. So overall, very significant consequences that are related to the gastrointestinal system, neurological symptoms, and endocrine systems. And then overall, there are some general consequences, like when someone is not getting the nutrition that they need, when they're not getting the calories and the fat, this can cause a person to have dry skin, their hair can become brittle and fall out. Also, for individuals who are anorexic, during periods of starvation, they can grow this real fine downy hair on their body that's called lanugo. When someone isn't getting enough of if they're not getting the hydration that they need, this can actually lead to kidney failure. I also want to point out too that when someone is not getting the nutrition that they need, this can decrease the number of certain types of blood cells. Also, a person is at an increased risk of anemia, where they have too few red blood cells, and this is because of not getting enough iron in the diet. So the person who's anemic may have fatigue and weakness and shortness of breath. And then I also want to mention too that malnutrition overall, especially when we're talking about anorexia and bulimia, but even with binge eating, if someone is not getting the nutrition that they need when they're eating large quantities of food, this can lead to malnutrition, which can decrease the amount of infection-fighting white blood cells in the body. Also, I think overall what's probably the most scary is that eating disorders can be deadly. And it's important to note that the mortality rate for disorders like anorexia, there's one study that I had recently read where they suggested that individuals overall, people with anorexia, have had a 6-fold increase of mortality compared to the general population. Now, I want to point out that it's not only the health consequences that I just mentioned that can lead to death of someone with an eating disorder. Sometimes when people have eating disorders, they may also have other comorbid issues, comorbid meaning additional psychiatric disorders that are coupled with that. So for example, someone with an eating disorder may also have major depression. They may also abuse substances. So sometimes when we see when we think about this high death rate that's associated with eating disorders like anorexia, for example, it can also be associated not only with the starvation, but with substance abuse and an increased risk of suicide. The treatment of eating disorders it's tailored to individual needs, and it can include medical care, nutritional counseling, medications such as antidepressants, and psychotherapy. When we think about eating disorders, there are different levels of treatment, from least intensive to what we might think of as most intensive treatment levels. So for some individuals with eating disorders, they may experience what we would call intensive outpatient or outpatient treatment. And this is where the person's medically stable and they don't need daily medical monitoring. And here, the person is going to be, they're able to function in normal social, educational, or work situations. And so they're not going to need to be hospitalized or stay in a setting for, for long periods of time. They may simply go to very frequent counseling. And then we have partial hospital, and this is where a person's medically stable and but their eating disorder seems to impair their functioning, but there's no immediate risk. And so when a person's partially hospitalized, they're going to need a daily assessment of their physiological and their mental status. And then we have residential. And so a person who's in a residential treatment program, they are also medically stable and don't require any intensive medical intervention. But psychologically, the disorder is having a significant effect on them. And then we have inpatient, and this is where a person is medically unstable. And when we say this, that means that their vital signs may be affected. Laboratory findings may show that they have a very serious health risk that's very acute. And then there may be some coexisting medical problems that could also be present. And so also a person who is unstable, they're typically having worsening symptoms. They may also be suicidal or, and they're in an unsafe mental space, so that they really could be likely to harm themselves. Well, there are different types of therapy as described in your textbook. And so one type of therapy that is listed in your textbook is cognitive behavioral therapy. And this is a relatively short-term symptom-oriented therapy that focuses on the beliefs that a person has, their values, and their cognitive processes, meaning their thought processes that they use to maintain that eating disorder behavior. And it aims to modify distorted beliefs and attitudes that the individual has about the meaning of weight, the meaning of shape, and physical appearance. And then we also have, before I talk about the Maudsley approach, I want to talk about a few other ones as well. Another is acceptance and commitment therapy. And the goal of this type of therapy is to change an individual's actions. The focus is not so much on thoughts and feelings. So the patients are taught to identify the core values, their core values, and to commit to creating goals that fulfill these values. And then in this type of therapy too, patients are encouraged to detach themselves from emotions and learn that pain and anxiety are a normal part of life. So the goal in this type of therapy isn't to feel necessarily really good, but to be authentic, to live an authentic life. And through living a good life, people often will find that they start to feel better. Another type of therapy is dialectical behavior therapy. And this is a type of therapy where the starting place is in changing behaviors. And so the treatment focuses on developing skills to replace maladaptive eating disorder behaviors. So there are also skill focuses on mindfulness, on becoming more effective in interpersonal relations, in emotion regulation, and in tolerating distress. And then we have the Maudsley approach, and I'm only mentioning a few, by the way. Of course, before I say Maudsley approach, let me also mention too that individuals can also benefit from what's just called interpersonal psychotherapy, and this is where a person is, the therapy really is focusing on what is it that's maintaining the disorder symptoms within the social and interpersonal context. And so there may be a focus on interpersonal deficits, on role transitions, interpersonal role disputes. So you can see here that these different approaches to therapy may each approach may work better for one person than it would for another person. And there are additional approaches that I have not mentioned here. And so really it's very important that when someone is going to be seeking treatment, that they understand the types of treatment, because I think that when you're understanding the type of treatment, then you would be able to best understand, potentially based on the type of treatment and what you know about yourself, what's going to work best for you. Because different therapies work differently for different people, and some may be more helpful than others depending on the individual and the stage of their recovery. The Maudsley approach is a type of therapy that can be specifically helpful for families with adolescents, because this type of therapy is not only focusing on the adolescent themselves, this type of therapy is also involving the family. And more specifically, this type of therapy includes parents, because there's a belief that parents play an active and positive role in order to help restore their child's weight to normal levels, given their child's age and height, and to help their adolescent to control overeating, and to really, in essence, by helping them, not being intimately involved in helping them to figure out how to control their eating behavior themselves, but by recognizing that the adolescent knows how to control their eating the best themselves. And then also to encourage normal adolescent development through discussing just crucial developmental issues that are specific to their child. So this is a very different approach in that the parents are directly involved, and there's a lot of research supporting the effectiveness of this approach as well. Before we move on to the next topic, I'm sure many of you have some idea of what may contribute to the development of an eating disorder. You may have thought about the role of the media. You may have thought about the role of a stressful home environment, or that potentially certain personality traits may contribute to the development of an eating disorder. I think it's important to note that risk factors for all eating disorders involve a range of biological, psychological, and sociocultural issues. And these factors interact differently in different people, so that two people with the same eating disorder can have very different perspectives and different experiences and different symptoms. So there are certain risk factors that put someone at a greater risk of developing an eating disorder. And we could group these, like I just mentioned, into biological, psychological, and social risk factors. So for biological factors, some of these risk factors include having a close relative with an eating disorder. Now, this is not only because of potential environmental factors, but this seems to be related to genetics. So that is one risk factor. Another risk factor is having a close relative with a mental health condition. So issues like anxiety and depression and addiction, they of course run in families, and having that in your family has also been found to increase the chance that someone will develop an eating disorder. Another risk factor for eating disorders is that is type 1 diabetes, and that may not be one that you've thought of, but recent research has actually found that about a quarter of women who are diagnosed with type 1 diabetes will develop an eating disorder, and the most common pattern is skipping insulin injections, which can be deadly. So some of the psychological factors include, like I had mentioned a moment ago, one related to personality traits, and that's perfectionism. So perfectionism, as you could imagine, could be a potential contributor because of having set unrealistically high expectations for oneself. And this is perhaps one of the strongest risk factors for an eating disorder. And this is especially true when it involves perfectionism directed towards the self. Another psychological risk factor is body image dissatisfaction. So body image is really about how do you feel about yourself in your own body. And as many of you know, it's probably for many of you or people and among you yourselves who are listening to this and people that you know, it's not uncommon to dislike your appearance. But people who develop an eating disorder are more likely to report higher levels of body image dissatisfaction than the general population, and also to have internalized an appearance of what they think of as the ideal physical appearance. And then also another psychological risk factor is having a personal history of an anxiety disorder. And so when people have anxiety disorders, this increases one's risk of developing uh, any of the eating disorders. So research actually shows that among anorexia, that many people with anorexia have signs of an anxiety disorder. And when we think of anxiety disorders, we're talking about generalized anxiety disorder, social phobias, and obsessive compulsive disorder. And when we say 2/3 of people with anorexia have an anxiety disorder, this is not once they have the eating disorder. This is before they were even diagnosed with the eating disorder, before I should say the onset of their eating disorder. Also, behavioral inflexibility. And so that's another risk factor where, as a child, you might, for some of you, you might remember feeling like you had to, there's just one right way to do things. Well, that actually is a risk factor for the development of eating disorders. And then there are social factors. And I think these are many that we could probably very easily think of. So when we think about this, a stigma of weight gain, and this, there's a message that being thinner is better, and we see this everywhere. And the research actually suggests that exposure to this can increase feelings of body dissatisfaction, which can then lead to eating disorders among especially people who are already more vulnerable. Teasing and bullying is another social factor. So especially if someone's experienced being teased or bullied about their weight. Another is the limited social networks. So when people have experiences of feeling lonely and isolation or isolated, this seems to increase one's risk, especially when someone's feeling like they have less social support, they don't have very many friends, and this is a risk factor. And then also another risk factor is what we call acculturation. And so when people who are from racial and ethnic minority groups, especially those who are undergoing rapid westernization, so someone who may have moved here from a non-Western country, and they are perhaps they're feeling the pressures of moving to this new country. They're experiencing stress. They're feeling, they're sensitive to the messages they're receiving about their body as it relates to the expectations for women and thinness. And so here we have these interactions between their stress, the acculturation of moving to this country and trying to fit in, and body image. And so that can increase one's risk of developing eating disorders as well. So these are just some of the risk factors, but these are some significant ones that I wanted to point out to you. As you've explored physical development in adolescence, you've learned about the overall physical growth happening during this time and the changes that happen during puberty. You learned about brain changes and changes in sleep, and you learned about gender intensification and nutritional concerns. You also learned about eating disorders and the prevalence and risk factors and consequences of adolescent pregnancy. So what will you be learning about next? Next, you'll be learning about cognitive development in adolescence. You'll learn about Piaget's fourth and final stage of cognitive development that he called formal operational thought. As you'll remember, You've already learned about the sensory motor period, and you learned about the pre-operational stage and the concrete operational stage. So now we're at the formal operational stage. You'll also be learning about something called adolescent egocentrism, and you'll learn about information processing research on attention and memory. You'll learn too about the developmental changes that are taking place in language and the different types of adolescent education. And then you're going to be learning about high school dropout rates that are based on gender and ethnicity. So I look forward to seeing you each online. And as always, if you have any questions as you're reading the material or after watching any of the videos, please don't hesitate to let me know.